Hi, everyone. Welcome to tonight's webinar with Dr. Elizabeth Mobley. This evening, Dr. Mobley will be speaking about bladder and bowel dysfunction, the common symptoms people experience, and treatment options that may help you regain bladder and bowel control. My name is Shannon Stemke, and I'm a field marketing specialist with Axonics and will be moderating this webinar. Without further ado, Dr. Mobley.
Hi, everybody. Thanks for joining the webinar tonight. I'm excited to talk to you all about bladder and bowel health and dysfunction that many patients deal with and ways that we can help manage that. Shannon mentioned I'm a urologist here in the Austin area. I did my medical training at the Medical College of Georgia. My residency was at the University of Utah, and my fellowship was actually in Auckland, New Zealand, and I came to Austin, Texas from Auckland. I have a lot of interest in urology. I'm a general urologist, but some of my passions are male and female urinary incontinence, benign prostatic hyperplasia or BPH, pelvic organ prolapse, and female pelvic organ reconstruction. Do a lot of robotic and minimally invasive surgery. Also treat a lot of stone disease, hormonal deficiency, do a lot of vasectomies. So really the gamut as it goes for urology. But what I'm here to talk to you about is something that I'm passionate about, and I take care of a lot. I take care of lots of patients with this problem, and we have great success in helping patients reach their goals of minimizing the distress of urinary and bowel incontinence. So I'm going to spend just a little bit of time going over the important safety information here. Axonics sacral neuromodulation therapy is indicated for the treatment of urinary retention and the symptoms of overactive bladder and urge incontinence in patients who don't have any type of urinary obstruction. It's there's a lot of potential risks associated with therapy that you and your doctor would go over if you decide that this is the right treatment for you. Further, there's some considerations in terms of how old patients are. The FDA has this approved for patients not under the age of 18 for fecal incontinence and 16 or older for overactive bladder and urge incontinence. There's a lot of potential risks, which you can see on the screen, and your doctor will go over with you at the time of the operation. But in general, a very well tolerated procedure. Bulkamid is a separate procedure done for stress urinary incontinence and stress predominant urge urinary incontinence in patients with sphincteric deficiency. A little bit different of a procedure with its own potential risks, but also very well tolerated. And I'll be going into detail on those, both those procedures here in just a little bit. Okay, so bladder symptoms can be extremely disruptive to your life, your activities, your interactions with other people, both at the home setting, but also out in work. This may be feeling like you constantly have to find a bathroom, you have to stop on trips. It's disruptive to the flow, it's disruptive to your family members and your friends and work partners that you're with. You may miss out on some best parts of the show or the game because you're having to run back and forth to the bathroom, or worried that you might have an accident, not know where the next bathroom is, or if you have a change of clothes on you. And this is an extremely common problem that we see all the time. And unfortunately, a lot of patients don't know that this is such a common problem. There are multiple different treatment options available to deal with these types of symptoms. So number one is y'all are not alone. If you're struggling with urinary and bowel symptoms, you should seek advice from a urologist, or at least your primary care doctor, who can get you into the hands of urologists who can help you with these types of symptoms. So we're going to start with overactive bladder. Just a little bit of background on this. Overactive bladder is extremely common. About 50 million Americans struggle with overactive bladder. And that includes symptoms of urgency or frequency of urination. If you don't know exactly what overactive bladder is, the hallmark symptom is that urge, that sudden compelling desire to have to use the restroom, urinate specifically. And it can be associated with urge incontinence, which is leakage, which happens in that situation. So urinary leakage or dribbling into your pants. Sometimes it may be small amount of drops. Sometimes it can be a flooding incontinence episode that you just cannot control. An additional 19 million Americans struggle from fecal incontinence. Okay, that's leakage or the involuntary loss of stool. And only half of those with severe symptoms ever seek treatment. Stress urinary incontinence is a common condition that affects 1 out of 3 women at some point in their lives. So it's a tremendous problem. A lot of patients will struggle with this really early on in life when they're young and playing a lot of sports. Some will deal with this when they're pregnant, maybe after giving childbirth, certainly during the end of pregnancy when there's so much weight, heavy on the pelvic floor, and then after delivery, especially vaginal deliveries where there can be some trauma to the pelvic floor and the support structures behind the urethra. So it's a very, very, very common problem, and it tends to get worse as we get older, like many things with the bladder and the bowel function. At the most basic level, it's really just important to understand what a bladder does, what its purpose is, and how the coordinated series of events happens so that you have proper bladder function. So the bladder's got to do two things. It's got to store urine, and it's got to be able to contract to empty urine. And during the storage phase, the bladder needs to be in a nice relaxed state so that it can accommodate more and more volume of urine. And the pelvic floor muscles and the urethra itself need to be contracted or closed. And that keeps you continent, which means you're not leaking urine. When it comes to emptying, first the pelvic floor needs to relax and the urethra needs to open so that there is a passageway for the urine to flow. And then the bladder needs to squeeze. And it needs to squeeze long enough and hard enough to completely empty the contents of your urine. And a lot of times, the bladder may not squeeze as well as it should. You may not empty all the way, or some patients can have full retention of urine, which is a separate problem to overactive bladder. There are patients that can have overactive bladder during filling where they constantly feel the need to urinate, maybe struggling with urgency and or frequency during filling. But then when it comes to empty, their bladder just doesn't squeeze as well as it should, and it's underactive. And that paradoxical situation does happen in quite a few patients, makes it a little more challenging to treat when you've got a really overactive bladder that we want to calm down, but you also have an underactive bladder that we want to get working better. So we have to be mindful of those types of situations when we're working patients up to make sure that they're not dealing with incomplete bladder emptying or retention of urine, which can drive incontinence symptoms. So that's part of the workup, is figuring that out. With regards to bowel function, as the rectum, which is the very far end or the very last segment of the large intestines, as it fills with stool, stretch receptors in the wall of the colon are activated. Nerve signals are sent to the brain, making you feel like you might need to go empty your bowels. And then to defecate or empty your bowels, the nerve signals coordinate the relaxation of the pelvic floor muscles first, and then the muscles of the rectum contract to push the stool out. And once the stool has been evacuated, the pelvic floor muscles tighten up again. The sphincter muscles, the external anal sphincter muscle, will tighten up, and that helps keep you continent of stool and of gas. Okay. Overactive bladder, again, is really the sudden urge to urinate, and it may be so strong that you're unable to hold it or control it, and you have an accident. You may not get to that point. You may feel like you're about to have an accident, but you generally can make it to the toilet. So there's overactive bladder dry and overactive bladder wet. Okay, same sort of underlying cause on that. It's just sort of progression of the disease there. There's retention of urine, which is where you have difficulty urinating, and that leads to incomplete emptying of the bladder. And there's multiple different etiologies for that. You can have some sort of an obstructive problem, so a blockage from the bladder neck down, where it's really not the bladder's fault, so to speak. The bladder's trying to squeeze, but there's just not an adequate passageway for the urine to get through. We see this a lot in men, much more so than in women, because men have prostates, and those prostates grow bigger. And as the prostates get bigger, they obstruct the urinary channel. And this can lead to disease of the bladder muscle itself, to where the muscle can lose its ability to contract or contract efficiently enough, leading to incomplete emptying. And then as that progresses, leads to retention. There's also patients that don't have an obstructive problem. Their bladders just can't squeeze very well. And that may be due to neurologic injury or insult or different neurological conditions that can cause retention of urine. Multiple sclerosis is one, of course, spinal cord injuries are the other. There may be radical pelvic surgery that was done for uterine cancer, ovarian cancer, or colorectal cancer that led to injury to some of the pelvic floor nerves that control the bladder, radiation therapy. There's a variety of different reasons that patients may develop neurogenic bladder dysfunction, and the bladder itself is just not getting the signal that it needs even though it's full, that it's time to go empty. And a lot of patients can struggle with retention of urine and not even realize that it's happening. They're able to urinate enough, like maybe off the top, what I call it, but they may not sense that they're actually still holding on to quite a bit of urine. Some patients are walking around with 3, 4, 5, 600 cc's of urine or milliliters of urine in their bladder and really not know it. And those patients can also have incontinence. They have what's called overflow incontinence. So that's frequently associated with retention of urine. Fecal incontinence is the involuntary loss of stool. And again, stress urinary incontinence is a little bit different than the urge incontinence. This is more of a urethral problem. It's more of an anatomical problem of the urethra, typically either due to excessive mobility of the urethra, meaning it falls out of its normal position when there's some sort of intra-abdominal pressure that pushes on the bladder and the urethra, and that extra pressure on the bladder, which pushes on it, pushes the urine out. Or it can be the sphincter muscle itself that's supposed to tighten around the urethra is not sufficient enough in its strength to completely close off the urethra during those times of higher stress or increased pressure, and the urine can squirt out. And sometimes it's a combination of the two. So that's more of a urethral problem, whereas the overactive bladder is more of a bladder problem, okay? Physiologic problem of the bladder. I've kind of gone over this, but a couple things to note. There's urgency symptoms, again, that, oh my gosh, got to go. And then there's frequency, meaning you have to go often. Some people can have frequency without urgency. They just feel they need to go a lot. It may not come on out of nowhere. It may be something that they can delay, but they're having to go to the bathroom often. And so the definition of that urinary frequency is 8 or more urinations in a day. Okay, that's in a full 24-hour period. Urinary urgency, again, can happen without frequency. You may only have to urinate 2 or 3 times a day, but when it comes on, that sensation comes out of nowhere and you better get to the bathroom super fast or else you're going to have an accident. That's urgency. So they can be separate or they can happen at the same time. Urge incontinence, again, is the involuntary loss of urine that occurs because of an urge-related episode. Basically, the bladder itself started to squeeze before you were in a socially acceptable position for that to happen, like on the toilet with your pants down and ready for it, okay? And then nocturia is when you get up at night or awaken at night 2 or more times and it's causing you distress. Now, some people have nocturia for a variety of reasons. It's very rarely solely a urologic problem or a bladder problem. It can be due to sleep apnea. It can be to a problem with the brain. It can be due to medications that you're on. It can be due to congestive heart failure and edema of the legs and the body trying to pull that extra fluid off at night. It could be polydipsia, which is excessive intake of fluids, especially in the later afternoon, evening, and nighttime hours. It can be from nocturnal polyuria, which is excessive nighttime production of urine. It can be from overactive bladder. So and that's a short list. There's a lot of different things that can potentially cause nocturia. Nocturia is a very frustrating problem, and it's one of the things that's the bane of urologists' existence because it's one of the more difficult ones to get exactly just right when we're treating it. But oftentimes, if there's a global overactive bladder, the nocturia will get better with the treatment that we're doing for the daytime frequency as well, or the urgency or the urge incontinence. So thankfully, we have lots to help that. It's just one of the more challenging ones. Fecal incontinence is the uncontrolled loss of stool, and that could be solid stool, it could be liquid stool, it could be mucus. And there's also some different differentiators here. There's fecal urgency, which is, again, sudden urge to feel like you're about to have a bowel movement. The fecal incontinence is when it actually comes out, when you're not ready for it, okay? And there's passive fecal incontinence, and that's leakage of stool without any type of awareness that it's happened. So those are patients who really didn't have a sensation they needed to have a bowel movement, and then when they get in the bathroom, they realize, oh my gosh, there's poop in my pants, you know? So that's passive fecal incontinence. We also see patients who have incontinence of gas. So they're passing flatus or gas, even though they didn't sense that it was about to happen, or they may sense it, they just can't contain it. Again, stress incontinence is a little bit different. This is more of a urethral problem, not a bladder problem. There's a couple different sphincter muscles in the bladder, surrounding the bladder, sorry, not in the bladder, but at the bladder neck and surrounding the urethra. There's an internal bladder muscle called bladder neck muscle that is not under your voluntary control. It's nice and closed when the bladder is filling with urine, and that needs to open when it's time to empty. The external sphincter muscle is the one we can contract and relax. That also has to stay closed during filling and open during emptying. We have some ability to modulate that sphincteric activity, but the bladder neck is under the control of the central nervous system. So sometimes with different neurologic conditions, we may see tightness of the bladder neck when it should be relaxed, and that can cause an obstructive problem. These types of conditions, all of them can definitely impact your quality of life. It can limit your activities and your participation in physical activities, social activities. It can be impactful to your sexual activity or your intimate, your love life. Occupationally, patients definitely struggle with dealing with frequency and incontinence at work. Having to have multiple, bathroom breaks can sometimes catch the attention of their superiors, and patients come in needing work excuses because they're having to use the bathroom so much. It can decrease their productivity. It certainly can be embarrassing when you have accidents at work. And it also can be stressful between patients and their partners or spouses or children because, dealing with incontinence is not the most glamorous thing, and helping your loved ones who maybe aren't in a position to help themselves dealing with diaper changes, especially with fecal incontinence, it's a burden, and of course we want to take care of our loved ones, but it gets hard. And unfortunately, this is one of the top reasons that patients end up in nursing homes, is because of specifically bladder incontinence, but bowel incontinence as well plays a big role in that. That's so that they can have other people, caretakers, that can help these patients as they get older, maybe aren't able to take care of themselves, but need this type of help on a frequent basis. So it's important to know, and I hear this all the time, oh, I am wearing pads, multiple pads a day, but I just thought that was part of getting older. Or I just thought this was what it's like to be a woman and have kids, and I'm just going to have accidents and leak, and I can't play with my kids on the trampoline. And, oh, just getting older, my prostate's gotten bigger, my weak stream, my urgency, that's just part of getting old, right? The answer is no, it's not a normal part of getting old. Does it happen frequently as people get older because of a variety of different things? Absolutely. But it's not normal. I wouldn't consider it normal. And there are many things that we can do to fix it. And in fact, fixing a lot of these problems helps prevent a whole lot of other problems down the line. So it's important not to brush these symptoms under the rug. It's important to get evaluated and talk to your doctor about it. It's important to find somebody that you're comfortable with, because these are kind of uncomfortable conversations for a lot of people. Many patients don't feel comfortable talking about it to their primary care doctors, or they may have nervousness or anxiety or feel stressed to bring it up to, let's say, a female patient to a male physician, or vice versa. You just got to find somebody that you're comfortable with, that you feel comfortable talking to, and bring it up. And I promise you can't say anything that we've not heard before. So we've seen it all, we've heard it all, we've dealt with all of it. We can help. All right, good news. As I was suggesting, there's many treatments for men and women that struggle with bowel and bladder issues, whether they're obstructive problems or these overactive bladder, urgent incontinence, fecal incontinence issues. There's many things that we can do. So, the first step, of course, is to consult with your doctor, whether that's your primary care doctor, who then can refer you to a urologist, or if you're able to just call and make an appointment with a urologist, you can start there as well. Initially, you're going to discuss your symptoms. Your physician may ask you to complete a bladder diary or a bowel diary to assess those symptoms, maybe get an idea of how much you're drinking throughout the day, how many times you're urinating. Some really important parts of the bladder diary specifically is not only how often are you urinating, but what's the time frame between voids, what's the volume of voids, i.e. sometimes patients at nighttime have to get up every hour or two and they're voiding little teeny tiny bits. But then during the day, they seem to can hold it for a longer period of time and they're urinating much larger amounts. Well, there's certain medical conditions that can cause that type of scenario. Is different than patients that are always getting up and voiding large amounts of volume, etc. So there's a lot of little subtleties within the bladder diary that we use to help guide our treatment path or figure out what the relevant issues may be. And then you'll discuss all that information with your doctor. There may be some extra tests that need to be performed. Sometimes we'll do urodynamic testing on the bladder or uro cuff testing for men that we think could have an obstructive issue, aggravating an overactive bladder issue. We may need to do some diagnostic screening studies like a cystoscopy, where we take a camera and take a peek inside of the urethra, the prostate for men, the bladder for men and women. Sometimes we have to do some ultrasound imaging to make sure that the bladder looks healthy, the prostate looks healthy, the kidneys look healthy, and patients especially that retain urine. That's super important. And for patients dealing with overactive bladder, the initial treatment options are going to be diet and lifestyle modifications and some bladder training exercises. Typically, we're recommending things in the diet that tend to be less spicy and less acidic and not carbonated. And alcohol tends to be a big offender. Coffee, tea, soda. And it's not just soda pop, it's carbonated water. Topo Chico's super popular around here, and that's a real big offender, or those types of drinks are big offenders. And it can be foods that you're eating that you're not realizing. The citrus fruits, the vinegar-based products, tomato-based products. There's a whole long list of things that can potentially aggravate these symptoms. Not everybody's sensitive to everything, but some people may have some trigger foods that once they are tuned in to thinking about it, they realize, oh, every time I eat oranges, my symptoms are worse. Well, might have you cut back on the oranges or cut back on the amount of Dr. Pepper or coffee you're drinking. Losing weight can help for patients who are overweight or obese. Definitely losing weight can help both the overactive bladder as well as the incontinence, both stress and urge incontinence symptoms. And then there are going to be medications specifically tailored for each of these individual problems. But for overactive bladder, we use medications. They come in two different classes. One's called anticholinergics. And these medicines block the receptors on the bladder that the parasympathetic nervous system uses to cause bladder contraction. Those medicines, there's a lot of them on the market. There's a lot of options that are out there, and they've been around for a long time. They work fairly well, but the problem can be side effects. And just a short list that I'll mention here, but dry eyes and dry mouth and constipation and sometimes cognitive issues can result from these medications, because not only are they slowing the bladder down, they're slowing down all those parasympathetic nervous system functions, like the bowel, which is why you can get constipated, or the lacrimal duct, so your eyes get dry, or the salivary duct, so you get dry mouth. So that's a common reason, or those symptoms or side effects could be common reasons why patients discontinue those medicines. There are beta-3 agonists, two on the market, Myrbetriq and Gemtesa, which are different. They work on a completely different receptor, the beta-3, they're beta-3 agonists, so the beta-3 receptor, which causes bladder relaxation. And so they work more in that storage phase of the bladder function to keep the bladder in a more relaxed state. And they work very well, and they tend to have different but fewer side effects, in my opinion. Gemtesa is very well tolerated, doesn't have many drug-drug interactions. Myrbetriq also generally well tolerated, a few potential interactions and some possibility of slight increase in blood pressure or heart rate with that medication. That's rarely seen, but it can happen. So we do have to counsel patients on those and make sure that we're picking the right medicine in light of all the other medicines they may be on. But those are two general options. For retention of urine, we may have to do some behavioral modification, timed voiding. What does that mean? It means setting an alarm or somehow setting a reminder that says, hey, I need to go urinate every few hours, or try to urinate. Some people are going 6, 8, 12 hours, or maybe even longer in some cases between urinations. That's not healthy for the bladder. Some patients have to do double voiding, so they think that they may have emptied their bladder, but they wait, they give it a little bit more time, they try to empty again. Some patients, if they're truly in retention, will need to start intermittent catheterization or some sort of way of draining their bladder, whether it's an indwelling catheter that's put in through the urethra or sometimes through the lower abdomen. For men with enlarged prostates, or for some patients that have bladder neck obstruction, alpha blocker medications may be the appropriate treatment. And then, of course, if we think there's some sort of a obstructive process going on, we need to deal with the obstruction for patients who can tolerate that type of procedure. If they're surgical candidates. If it's an enlarged prostate that's blocking the channel, we need to get rid of that, reassess, hi, or you've had your transurethral resection of the prostate or your aquablation or your urolift, give it some time. Are you able to urinate? And if not, and if we've dealt with the obstructive problem, we're confident we've gotten that out of the way, and some patients are still not able to urinate, then we may be able to use sacral nerve modulation, which I'll speak to in a minute, to help get that patient urinate again. And then with fecal incontinence, dietary changes, things that you can use to sort of bulk up the stools can often be helpful. Anti-diarrheal medications that you can get over the counter, like Imodium or Lomotil, sphincteric and pelvic floor exercises, which, by the way, can also help overactive bladder and stress incontinence, of course. Pessaries can be used for fecal incontinence as well. When you don't see any improvement with these initial more basic or lifestyle dietary changes, maybe medication therapies, that's when we get into more advanced therapies. And that's where my life gets to be more fun, is I get to, do what I do best, which is I'm a surgeon. I get to operate, try to help people fix their problems. And with overactive bladder and with urinary retention, non-obstructive urinary retention, one of the treatment options is sacral nerve modulation. For overactive bladder, there's also something called percutaneous tibial nerve stimulation, and there's also percutaneous tibial nerve implants that are implantable tibial nerve stimulators, very similar in concept to the sacral nerve modulators. There's chemodenervation of the bladder, which we use Botox to do this. So Botox is a paralytic agent. We use it in teeny tiny doses injected into the bladder to help calm the bladder muscle down. So that's often used for overactive bladder and urge incontinence. For the urinary retention, again, sacral nerve modulation is an option if there's no obstructive problem going on, intermittent catheterization like we talked to, and then the surgical intervention. Those would be more of the advanced therapy, so to speak. For fecal incontinence, there's also sacral nerve modulation, which I'll get into. Again, I'll touch on all of that when I go through the sacral nerve modulation portion of this. Transanal irrigation, which is the use of irrigation to try to clean out the stool and do it in a more controlled manner. And then there's surgical sphincter repair. So this is just a schematic or a depiction of posterior percutaneous tibial nerve stimulation. So PTNS is what we call that for short. PTNS is an office-based procedure where we place a small little needle, almost like an acupuncture needle, into the ankle area. It's sort of behind the medial malleolus, just above there. The posterior tibial nerve runs deep in that region, and that nerve travels up the leg. And the way I kind of think about it, or try to get people to understand, is it crosstalks with the main bladder nerve. So we can stimulate that tibial nerve, and over time we can see it affect the main bladder nerve and lead to modulation of bladder symptoms. So this is a treatment done, again, in the office, where you come in once a week for 12 weeks. These sessions are typically 30 minutes. So you come in, you get the needle put in, and a little stimulation device is connected to that needle. It sends an electrical stimulus to that posterior tibial nerve. You might feel a little sensation of tingling, or a little like an electrical shock, nothing painful, but very subtle shock kind of feeling in the foot, going up the leg. And you sit there and hang out for 30 minutes. And at the end, we just take the needle out, you go on your way, and you come back once a week for 12 weeks. So we do that. Some patients will start to see improvement by 5 to 6 weeks. Some patients won't really see any improvement until week 10, 11, or 12. So when we counsel patients about this, we say, look, if you're going to go for this, you really got to commit to the 12 weeks, because some people really won't see it happen. And then it's like a light bulb goes off at 12 weeks and they're like, oh my gosh, I'm better. So we typically will see them back after their 12th session a week or two later, ask them how they done. And then if they seem significant enough symptom improvement to move forward with ongoing therapy, we move them to generally once a month treatments thereafter. Okay, so that's the maintenance. I don't have a slide on the implantable tibial nerve stimulators, but there is one that's currently FDA approved, and more are forthcoming. The one that is FDA approved is called eCoin. Botox injections are done in the office typically, though they can be done in the operating room if somebody needs to be more heavily sedated under anesthesia. But it's a fairly simple procedure where the Botox medication is mixed with saline to make it a solution, and then that is injected through a tiny little needle, which we place through a camera, which is placed inside the bladder. And we inject it sort of around the bladder muscle in multiple different areas. So you get somewhere between, every physician's different in how they do it, but 10 injections, 20 injections, sometimes up to 30 injections, depending on the template and the amount of medication that's being used. But this medication really works to calm down urgency, frequency, and urge incontinence. It's definitely not going to help you with retention of urine. It can make that worse. In fact, that's a potential side effect of this type of therapy, is that for some patients, it works too well. And for a period of time, they have trouble emptying their bladder. So they may have incomplete bladder emptying or rarely complete retention of urine. So patients who choose to undergo Botox have to understand that. And if they're in the small percentage of patients that have that as a side effect or a complication of the procedure, they have to be willing to either catheterize themselves to drain the urine if that need arises, or have a catheter put in until it wears off. But Botox does wear off. So even if you love it and you think, oh my gosh, this is the greatest, you're going to have to plan on coming in about twice a year to have the Botox topped off. So a lot of patients do that. A lot of patients like it. A lot of patients are a little hesitant given the retention of urine, but that's a discussion that you and your physician would have as to what option might be best for you. And to be quite honest, some patients need multimodal therapy where they may end up getting Botox plus medication or Botox plus sacral neuromodulation or vice versa. This is a depiction of the sacral nerve stimulator, and sacral neuromodulation modulates the activity of the third sacral nerve typically to help restore bladder and bowel function. The therapy is often done with a trial procedure first. In fact, that's generally required, whether it's bladder or bowel incontinence issues. And that trial procedure can be done in the office or in an operating room under some sedation. And that requires placing these small little typically temporary thin wires through the back in the lower buttock region. Well, it's actually the upper buttock, but the lower back region. And it's done by using these little needles that are placed in to the correct position. We stimulate to see what muscles move. And then when we're in the right spot, we place these small temporary wires. We take the needles out and they're taped into position, these wires, for a period of time, 3 to 5 days typically. Sometimes we need to do longer. And that gives patients a chance to try out sacral neuromodulation to see if it works for them. So this percutaneous nerve evaluation is really a diagnostic test of sacral nerve stimulation or modulation to see whether a patient likely will be a good candidate for a full implantable system moving forward. And I'll go into a bit more detail later on in the slide deck about this. But if you have a successful trial, generally speaking, at the end of the trial, those wires just pull out. So if you didn't like it, you didn't like the stimulation, you didn't notice any improvement, you didn't like the sensation, you can't wrap your head around sacral neuromodulation, at the end of the trial, all we do is take the wires out. There's nothing permanent left behind. You didn't get any unnecessary incisions. You didn't have to go back to the operating room. But if you love it, the wires are just going to come out, and then we generally would get you set up for an actual implant of the full system. For stress incontinence, I want to talk a little bit about that here. So pelvic floor physical therapy or pelvic floor strengthening exercises like Kegel exercises can be very helpful, especially if you have milder stress urinary incontinence. We certainly offer a couple different surgical interventions. The bulking agent Bulkamid has kind of, in my opinion, supplanted all other bulking agents that there ever were, and it's really, I think, quite a step up from what we've previously had for bulking. So what is bulking? Well, it's an injection of a filler. That's a good way of thinking about it. A filler under the mucosa of the urethra to kind of plump it up, okay, to create more outlet resistance. So think lip filler. If somebody wants more plump lips, they go to the dermatologist or plastic surgeon. They get these little injections, and now their lips are nice and plump. Well, it's a very similar concept to what we're doing with Bulkamid, which is the urethral bulking agent. And there are a few other bulking agents on the market, but the thing that differentiates Bulkamid is that it's a non-particulate gel, a water-based gel, that doesn't leave any kind of foreign body behind. It doesn't create scar tissue. It doesn't migrate. And the volume that we inject, which is key, stays there. It's moldable. It's easy to get yourself out of trouble if you over inject it. So it's just been a real game changer for the bulking options that we've had since that's become available here in the United States. And of course, there's surgical slings, and slings typically, not always, but typically are what we call little mesh hammocks that sit behind the urethra and lift and support the urethra. So if you've got more hypermobility of the urethra, what I mean by that is on exam, if somebody coughs or bears down, pushes, and we see that urethra falling down and forward, that urethra is not well supported. It can't close when it's in that position. And when you cough or sneeze or pick up something heavy, the urine's just going to flow out. If you have a lot of that, you're going to need a sling typically to lift the urethra back up, put it in its proper position so that it can close properly. Some patients may need both. They may need a sling to lift. They may need the urethral bulking if their sphincter muscle is deficient. And even though we've lifted it, it's still not able to close. Okay. So lifestyle changes can also help. Again, diet and exercise make a big difference. Pelvic floor strengthening exercises. Quitting smoking can help with the I guess the pelvic floor muscle tone. It can help with the fascia or the connective tissue that supports the urethra. Smoking also tends to lead to chronic coughing and COPD exacerbations, and all that coughing just puts an extreme amount of pressure on the pelvic floor, which can exacerbate stress incontinence. If we're ever going to do surgical intervention, especially slings for stress urinary incontinence, we generally don't want our patients smoking. That can really impair wound healing. Pelvic floor exercises such as Kegels can help improve the strength of the pelvic floor. It can help with moderate forms of prolapse, which is also a condition frequently associated with stress urinary incontinence. Some patients can do this on their own at home. There's multiple websites that you can find online that can help you with pelvic floor strengthening exercises, but also we really encourage patients to at least meet with a pelvic floor physical therapist one or a couple of times to make sure they're doing these exercises correctly to get the most out of them. The mesh sling is, often for a lot of surgeons considered to be the gold standard of treatment of stress urinary incontinence. It's been around for a very long time. There's a lot of different slings that are out there, and there's a lot of different versions of the sling. There's retropubic slings and transobturator slings and mini slings. There's also non-mesh slings called fascial slings, and we can use patient's own fascia or we can use cadaveric fascia. These are all put in slightly differently, but in general, they have very good success rates and they have pretty good longevity on the success. So 80 to 90% success out to 17 years follow-up. There are some patients who may not be good candidates, especially for mesh sling, patients that are young, patients that are not done having children, even though the AUA sort of changed their stance on that recently in the last guidelines. Doesn't preclude, if you're not done having children, doesn't preclude you from having a mesh sling, but you may want to consider bulking as a better option in that patient until they're done having children. Again, putting mesh in patients that have very poor quality tissue or smokers, immunosuppressed, on steroids, not willing to comply with sort of the follow-up regimens, etc., may not be best suited for a mesh sling. You want something a little less risky with fewer potential risks. And again, that's where urethral bulking can come in so handy for a lot of patients because it's much lower risk than any type of mesh sling. There's no incision required to put in the bulking agent, but it's just done through a camera where we place the camera inside the bladder and draw back into the urethra. And we use a needle and typically inject the medication around the mid portion of the urethra in a 3 or 4 quadrant fashion. Again, very low risk. Minimal downtime for the patient. They can get back to their normal activities the same or the next day. It can be done in an outpatient setting in the office. Oftentimes we can offer it in the surgery center if patients want a little bit of sedation because it can be a little uncomfortable to inject, but most patients do great. Okay. So I want to focus a little bit about sacral neuromodulation and specifically Axonics therapy. So Axonics is a version of sacral neuromodulation. There's a couple different options that are on the market. Axonics is one of the newer technologies out there that's really advanced sacral nerve modulation. And they are FDA approved for use in overactive bladder, urge incontinence, non-obstructive retention of urine, and fecal incontinence. These conditions, again, it's a miscommunication between brain and bladder. And what the goal of this therapy is to help restore that communication between brain and bladder. Nobody can fully explain exactly how it works and how it can help patients that have seemingly complete opposite problems, urinating too much, having accidents, and then not being able to urinate at all, but it does. And it's pretty cool that we have one therapy that can treat that variety of symptoms. And some patients have multiple of these symptoms, if not all three of them, happening all at the same time. So it's really great for those patients to be able to say, look, we've got this one therapy that may fix your overactive bladder, your underactive bladder, and your fecal incontinence. Doesn't get better than that. So, again, if we think it's the right thing for a patient, and we may need to do a bit of testing up front to make sure that we're not, missing something and we need to take an initial step in another direction. But once we're comfortable that that's what needs to happen, we'll do a trial period. And if that trial shows that you see significant symptom improvement, which is generally going to be 50% or more reduction in your symptoms, whatever they are, then you're a candidate to move forward with the full implantation. And this is a depiction here of the two different systems for Axonics. There are two different battery options. There's rechargeable batteries. The rechargeable battery here is on the left where my cursor is. It's a slightly smaller battery. The batteries, you need to recharge every 6 to 10 months. You don't have to recharge them for very long. An hour probably will take care of it. And these can last 20 or more years. So for younger patients who have a lot of 20-year increments ahead of them potentially, this is a really nice option because it reduces how often they're having to come back to have battery exchanges. But you do have to maintain it. You've got to remember to charge it. If it runs out of battery or gets completely decharged, your symptoms might show up somewhat thereafter, and you say, oh my gosh, why am I leaking? I forgot to charge my device. So there's that. The little handpiece here is the same for both systems, whether it's a rechargeable or non-rechargeable battery, but this is what patients use to control it. They can turn the device off and on or up or down. On the right side, we've got the Axonics F15 battery, which is the non-rechargeable battery. So there's nothing in this system to recharge. You don't have to recharge the battery. In either case, you don't have to recharge the handpiece. If it ever runs out, they'll just give you a new one. This battery can last 10 to 20 years, maybe more sometimes, depending on how low we're able to get the thresholds where the nerve's getting stimulated. And if you're not using up that much juice, it potentially could last longer. But, we quote people 10 to 20 years. It's a very, it's kind of hard to appreciate in the pictures, but these are thin devices, okay? So they're very, small. This rechargeable, requires maybe an inch incision, and the non-rechargeable, maybe a 4 centimeter, 2-inch incision, just under 2 inches to put those in. All very superficial, all tucked in on the upper outer buttock region. Once it's in place, you won't be able to see it from your profile. Nobody would really know you have it. We do get the question a lot of what happens if I go to the airport and I go through a metal detector? Yes, that would, sound the alarm bells or whatever. We give you a little patient device. I have an implanted device card, just like if you had a pacemaker or something like that, so that they would know you're not, it's all legit. This again is the handpiece, very easy to use. It's discreet, it's pocket size, it's not large, it's not intimidating, okay, to use. And these are, and contrary to how this used to be, these are conditionally approved to have MRIs of the body. So there used to be this problem where the magnet of the MRI could heat up the components of these sacral neuromodulator systems, and it wouldn't be safe to get an MRI while you had those in. We'd have to take them out if somebody that developed the need for the MRI, or if somebody had an ongoing need for MRIs, they've got multiple sclerosis or back issues or have to be followed for other conditions with MRI, we wouldn't be able to offer this therapy. So this has been huge step forward, being able to still offer this type of therapy in patients who may need MRIs. We do need to turn the device off for you to have your MRI, but it's pretty easy to do that. Turn it off, turn it back on when you're done. Sometimes I'll have to slow the sequencing of the MRI down for some of the sacral neuromodulators that are on the market, not always, but it is possible to get your MRI and you do not have to have the device taken out. So that's really important update there. And about 93% of patients achieved clinically significant improvements in incontinence symptoms at 2 years. So they saw the therapy work, they went and got the device put in, they're still seeing improvement in their symptoms at 2 years. 94% of patients are satisfied with their Axonics therapy, and 93% of patients surveyed would go through the same procedures again to get their Axonics device implanted. So we see really high success rates and really high satisfaction rates. My levels of satisfaction and implantation rates are going to be in line with this. Bulkamid, again, minimally invasive, non-mesh alternative to stress incontinence. This is a water-based gel that is injected into the mucosa of the urethra. I think we've got a small, quick little video here that kind of depicts that.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
We're just trying, again, this is depiction of the urethra, and we just go into 4-quadrant fashion typically and inject a little bit of this bulking agent at each site. So as it's injected, you kind of see this tissue ballooning out. And when you do it in all 4 quadrants, you end up getting a nice, just a much smaller opening. It's not so much that patients generally will have trouble urinating through it. Of course, that's a concern. That's a potential risk as patients have trouble emptying their bladder afterwards. But because of the fact that this gel is moldable, if somebody is really struggling and it's been a couple days since surgery or procedure, we can pass little tiny catheters in to gently flatten those cushions out and try to tailor that or taper that so that the patients now can urinate, but hopefully aren't struggling with the incontinence anymore. So it's been really nice. It's been a huge addition to my incontinence practice. 92% of women improved being cured or improved following treatment with Bulkamid. It's generally a very quick procedure. I do most of mine at the surgery center under just a slight sedation so the patient isn't moving while I'm trying to get it in the exact spot I want it. I think that's really critical, is to get those nice blebs. You can't have a patient moving while you're putting it in, or your needle's not going to go in that right plane. Some patients may need a second injection to get it just right, but we're seeing really great results with this.
Well, yeah. Great. Well, thank you so much, Dr. Mobley. That was so informational, and you can really tell how passionate you are about the therapy. It was really fun to listen to you.
Awesome. All right, great. Well, yeah, if anybody of you guys have questions, feel free to call my team and get an appointment. I'm happy to help you out. Okay.
Great. Thank you. Thanks everyone for joining tonight.